Good morning. I'm Tim Morehouse. I'm the Director of Community Partnerships with Alberta Children and Youth Services. And I'd like to welcome you for attending today's session with Dr. Sterling Claren on FASD screening and diagnosis implications for two. Before I introduce Dr. Sterling Claren, there's a few housekeeping tips. All of the sites have been muted at the bridge, but please ensure that your mics are also muted. If you have questions for the presenter, Dr. Claren's contact information can be found at the back of the handouts or the information. And if you experience any technical issues, please let your local site contact know, and they'll follow up accordingly. We're also quite pleased to let everyone know that today's session has 64 sites attending. BC has 2 sites, the Yukon has 1 site, Northwest Territories with 4, and Nunavut with 2 sites. Saskatchewan has 12 sites participating, and there are 4 sites in Ontario. And the remaining 39 sites are from Alberta. We're anticipating that there's over 140 participants today, so we're looking forward to a great 2 hours with all of us. Education and training is a critical aspect in the FASD 10-year strategic plan that the Government of Alberta has continued to address through various initiatives, such as the video conferencing and learning sites, and one of those we're doing this morning. We're pleased with the ongoing interest and attendance for these initiatives, and again, thank you for your participation this morning. I have the pleasure of introducing Dr. Sterling Claren this morning. Dr. Claren is the CEO and Scientific Director of the Canada Northwest FASD Research Network, and is a clinical professor of pediatrics at the University of British Columbia and the University of Washington. Dr. Claren has applied his training in dysmorphology, neuropathology, neuroembryology, and developmental pediatrics to the problems of FASD spectrum disorders since 1975 in clinical diagnosis, clinical evaluation and intervention, and clinical and basic research. Dr. Claren wrote the first major summary article of the clinical pattern of malformation associated with alcohol tetrogenesis in the New England Journal of Medicine in 1978. He was co-author of the 4-digit diagnostic code for FAS-related conditions. This last work has recently been accepted as the Canadian standard for FASD diagnosis. And Dr. Claren developed one of the first pediatric clinics focused on difficult diagnosis of FAS and related conditions in 1978, and has refined the clinical approach over many years. I've had the pleasure of getting to know Dr. Claren as the Canada Northwest FASD Research Network began its journey under his leadership, and I've come to appreciate that whether he's speaking to medical colleagues, working with professionals in the field, working with children and their families, or working with politicians and bureaucrats, Sterling's passion, commitment, and beliefs that we can cause positive change in relation to FASD underscore his presentations and his work. Would you join me in welcoming Dr. Sterling Claren?
Thank you very, very much. It's a pleasure to be with you all today. It's a little odd, frankly, to be looking at pretty much an empty room and knowing that you're all out there in so many places. But hi, we are all here today to struggle with what's actually quite a complex question, which is screening for fetal alcohol syndrome. And I asked that the title of the lecture be changed from screening, which was the primary topic and purpose of this lecture, to diagnosis and screening because I thought it was very important that we sort of consider both terms and how they're linked to each other. And when you're doing screening, of course, screening is basically detective work. This is sort of the CSI of the field. What are the clues in the person that you're seeing or in the community that you're evaluating that would lead you to conclude that someone might need further assessment for any condition? And so we can approach this as who, what, why, when, and where, and eventually, over the course of this lecture, we will. The first question is, what's the target that we're seeking to evaluate? What are you screening for? Unless you know what you're screening for, of course, you don't know how to look for it. And one of the technical problems we have today is that I put slides together to make specific points. The folks who prepared your presentation notes felt that there was too much text on my slides to print the copies for you. Consequently, they divided my slides into parts. Sometimes one of the slides that I'm showing here in the room has 2 parts in your handout and occasionally 3. And this is the first one that I'm showing as one slide that has 2 parts for you. It might help if, in order for us to stay in the same places, for you to number the pages in your handout. By my count, the handout has 27 pages. And the slide that I'm showing right now on the wall is the last slide on page 1 and the first slide on page 2. That's important because it's important to simply see the difference in the lines of type. When we define fetal alcohol syndrome, it is, of course, a syndrome defined as a dysmorphic condition, a clinical genetic condition, although this condition isn't genetic. But this is a non-random, recognizable pattern of malformation. And when you see everything that's part of a syndrome, we can separate that pattern from other recognizable patterns of malformation. So fetal alcohol syndrome then is defined as a specific set of facial anomalies with growth deficiency, an atypical presentation of brain development in the context of alcohol exposure. Unlike most syndromes, the exposure is a critical piece. For most syndromes, we define them by the physical features alone. Smith-Lemli-Opitz syndrome, even Down syndrome, the orofacial digital syndrome type 4. All of these different kinds of names for syndromes are defined by the body parts that are involved, and then we do tests when we can to confirm the diagnosis. So we make the diagnosis of Down syndrome, we then do the genetic test that confirms trisomy 21 or sometimes some other genetic form of anomaly that causes Down syndrome. But Down syndrome is Down syndrome. Now, it would have made sense for fetal alcohol syndrome to have been labeled in the same way. It would have been reasonable to have called this phenotype Smith-Jones syndrome after the clinicians who found it, and then to confirm that alcohol caused it by getting that history. Dr. Smith decided to go against convention when he named this condition, specifically because of its potential for prevention. He wanted the world to understand that alcohol caused this condition. He moved out of a medical system that works very well and picked this term for that preventive purpose. That's an important thing for us to realize today when we're talking about screening, since screening is an important step in prevention. Anyway, that's FAS. And if you look at now what we understand to be the spectrum of fetal alcohol spectrum disorder, you can see that the lists are basically the same. It makes sense, of course, that if you start with an agent like alcohol and expose a large variety of people to the same drug in utero, you wouldn't get the same anomalies coming out. In fact, it's a lucky break that there's a syndrome there at all. You'd expect one person to have a heart defect, one person might have brain damage, another child might be small, based on exposure, dose, and so on. So it's very easy to think of a spectrum in this case, but when you look at what we've defined as the spectrum versus what we've defined as fetal alcohol syndrome, really the only difference is the facial features. Growth deficiency can be found in either group. We don't hold that closely to saying people have to be growth deficient, and we'll explain that later. They may or may not have other organs involved, like the heart or the kidneys. But it's the link of a certain kind of atypical brain development with a specific set of facial anomalies that really just simply define the syndrome, and the lack of that face defines the rest of the spectrum. So who is being screened? Well, we now know that fetal alcohol syndrome is often a multi-generational problem. Adults who have FAS and FASD can have children with FAS and FASD. Whether that's an environmental issue completely or that there are genetics that often direct who becomes an alcoholic isn't clear. There's no evidence that FAS itself is genetic. Frequently, the needs of the child and the needs of the mother are quite different, especially if the mother is an alcoholic who does not have FASD herself. But even if she has FASD, her clinical condition and her child's condition might be quite different. So unlike genetic conditions that breed true, even if there are multiple members of the family who have the same thing, their needs and functional disabilities might be quite different. Nevertheless, identifying everyone is very important. This is a system problem. Everyone in a family with folks with FASD is affected, and of course all the systems working with them may be impacted. But we want to try to evaluate and recognize everyone in a family who might have this condition. Generally, the only way to recognize other family members, and especially the mother, is through the recognition of the first case. If you will, finding one child with FAS or FASD is a biomarker for problems in the rest of the family. While this is an obvious logical deduction from knowing about fetal alcohol, and while it has been part of the field's consciousness since the term was coined, there has been relatively link in Canada between the utility of making a diagnosis and linking to the systems working with the mothers. It's been a striking disjunction across provinces and across groups thinking about this problem. The next slides occur on my page 3 and go on page 3 and basically all of page 4. I have this on 2 slides. You have it on about 4 or 5, maybe 6 slides. The World Health Organization has talked broadly about what you need to have in place before you screen for any disorder. And I think it's really important that we look at this list before we start thinking about how we're going to screen for fetal alcohol, or if we even should. According to WHO, a suitable test for screening exists. The disease or condition that is being screened for should be important medically, socially, and economically. The natural history of the disease should be understood, and the population at risk should be identifiable. The test should be acceptable to the population. The condition should be recognizable at an early age or an early stage. There must be an accepted and effective treatment for the condition, otherwise why bother? There should be facilities for assessment, diagnosis, and rehabilitation. Intervention should be acceptable to the population. The cost of screening should not be disproportionate to the cost of caring for the affected individuals. And screening programs should be a continuous process. When we look at this list in terms of what we have available in our knowledge of FAS, we don't meet all of those criteria. First, should a suitable test exist? I think we will go through all of the ways we could screen for FAS, and the answer is, I'm not sure. The disease or condition that is being screened for should be important medically, socially, and economically. Well, that's certainly true. The natural history of the disease should be understood, and the population at risk should be identifiable. Well, not quite so clearly, but probably reasonably so. The test should be acceptable to the population. Well, we haven't done any field trials to know if any test is actually completely acceptable to the population. But we have a hunch, don't we, that some folks in the community are ready for this diagnosis as a community, and some communities may not be ready for this diagnosis. The condition should be recognized at an early stage. Not completely clear that we can recognize it as early as we might like to, but we can certainly recognize it in childhood. There must be an accepted and effective treatment for this condition. That's completely hypothetical in our case. There should be facilities for assessment, diagnosis, and rehabilitation. Well, there are, but they're probably globally inadequate. If it's true that 1% of the population has this condition, then in all of Canada that would be about 32,000 folks. And let's say that 2/3 of them are under the age of 20. It does seem that there is more FAS now than there was perhaps in the births right immediately after World War II and in the 50s and 60s. Possible. But anyway, let's just say that there's some gradient there. We have a capacity in all of Canada of identifying less than 1,000 people a year with fetal alcohol syndrome. And if we have perhaps another 1,000 or 2,000 children with this born each year, we're actually getting farther away from a full capacity to diagnose everyone who's screened than approaching a capacity to do this. Intervention should be acceptable to the population. Again, I don't think we know enough to know the answer to that question. The cost of screening should not be disproportionate to the cost of caring for affected individuals. Well, I think that's clearly true. We believe that the care of each of these children is many hundreds of thousands of dollars, if not more. And so screening is certainly going to be cost effective. And screening programs should be a continuing process. Well, they're not in place now, so they aren't a continuing process, but if we're going to put them in place, we probably really need to be planning for that process. So why should we do this at all? I think we get to the answer of why by answering the question what. What is it, in fact, we want to screen for? What is the social problem? What is the issue here? It's certainly not the face of FAS, and it's not a growth problem. What we're screening for is brain damage. That's the problem. Alcohol alters the structure of the brain. We'll talk a little bit more about that later. But this form of brain damage manifests itself in the world as a problem of adaptation. These children are not making it in their world, at home, with their community of children that they know, at school. That's the bottom line. They're not making it. And the problem does not necessarily seem to be linked in a convincing fashion to problems of temperament or mood, health, adversive experiences in early life, or other problems in their environment. These may be present, but they don't seem to explain the depth and persistence of the adaptive disorder. So at this point, I'm on to page 5 of your notes, and we're up to the bottom slide on page 5. These flip very quickly, These are just pictures to show us that where the level of brain damage is. This first picture of a normal child brain and an infant brain with fetal alcohol is a picture that comes from my first paper that Tim mentioned, 1978. This picture has been published and published and published as an example of the brain of fetal alcohol syndrome. Now, this is the most severe example of the brain of fetal alcohol syndrome. But there's only been one other brain ever brought to autopsy that looked as bad as this. And this child, of course, died in infancy because of the massive malformations of the brain, very different than people who survive with FAS or FASD. So while all the structures of this brain explain to us how diverse and profound the impact of alcohol on the brain can be, this is a very bad example of what's usually going on in the head of somebody with FAS. It wouldn't take, a neuropathologist to look at the picture here on your right and go, yes, that's a very malformed brain. But for people who survive after damage to brain, they tend to have more normal brains. Again, when they present with IQs below 60, when they present with head size that are -3 standard deviations from the mean, and it's already clinically clear that their brains are abnormal, if images are obtained, like MRIs, of those sorts of kids, we see a relatively high rate of structural anomaly, as in the case of the picture of corpus callosal anomalies. And in the slide that you have in front of you, there are 5 images of the midline of the brain going from a normal corpus callosum in the upper left-hand corner to a completely missing corpus callosum in the bottom right-hand corner. The corpus callosum is a large white matter band that connects the axons, the communication channels from one side of the brain to the other. Without a corpus callosum, actually, the two sides of the brain can still communicate, but not as effectively. There's nothing special about the corpus callosum. It's just easy to see, and it's easy to see when it's not there. But this is not a good clinical marker for FAS either, since when it's missing, chances are you already knew the child's brain was impaired just from looking at the child across the room. So clinical MRIs have not yet been that helpful. The lesions are usually more subtle than that. When we get to more increasingly research-based kinds of tools, looking at gray matter densities and volumes, looking at functional MRIs and PET scanning, SPECT scanning, MRS, MEG now, we begin to see the level of the lesion, which is microcellular, microscopic, and at the level of function. This is completely compatible with the animal literature and is absolutely of no surprise. So how on earth, given our technical tools for looking at brains of people who are alive who do not want their brains biopsied or removed, how do we detect microscopic and microcellular lesions? As I said, most of the time clinical imaging at this point in time is going to be normal, 85% of the time, and in the 15% it's always pretty obvious that it was not going to be. We infer that the lesion is similar to that in animals, and what we are left with then is a battery of tests that measure performance. And so the assumption is that if we broadly test brain function and find diffuse forms of discrepancies and abnormalities, that suggests that the brain is diffusely damaged, which is what we would expect to find from something like alcohol. So just as alcohol abnormally affects every part of the brain, it also abnormally affects every part of function. And on this picture, which now shows up on page this is on your page 8, and it's actually the whole page. So problems with regulation of state occur from the brainstem. Problems with balance and coordination are in the cerebellum. Attention and the whole broad concept of attention, not just simply ADHD, but awareness, reactivity, anxiety, all associated with the limbic system. In the cerebrum, we have problems with speech and language, which we think largely are in the left temporal lobe, executive functioning and reasoning, which come largely from the frontal lobes, the prefrontal lobe. And there are multiple locations for learning, memory, and cognition. I'm not exactly sure what the tonal anomalies are in the brainstem that are also affected, but they're undoubtedly there. And when you have sort of subtle function problems across the whole brain, the final common pathway then is adaptive skills. Whatever your particular pattern of problem, person one can have one pattern and the next person can have quite a different problem and a third person can have something in between. And we rarely find any two folks who've been damaged by alcohol of exactly the same pattern across all these domains. But what brings it all together is adaptive function. On testing, the kinds of testing that make it most obvious are tests that are hard, that require a lot of brain. So asking a child to tell a complicated story, write a poem, do a word problem in math, solve a problem around the house. Things that sample multiple brain bits, asking the person to find those parts of their brain, bring them all to active memory, put them on the table, move them around, plan and use all of that stuff at the same time. That's when you start to see that the brain is abnormal. The simpler the task, the more likely it is that a child with FASD will be able to perform the task. My colleagues in psychology, including my wife, who's a neuropsychologist, hate this particular slide. It's on your page 9. It's at the top. But you could take all of those brain bits and use an acronym, a mnemonic, alarmers, which of course is misspelled. But that's a way for all of us to remember all the domains that may be abnormal in FAS. And what we find in clinic, and it's been found repeatedly, is that in any child who has this sort of form of mysterious adaptation, it's important to sample at least 5, if not 6, of these domains before the team is really comfortable that the cognitive profile does or does not explain the adaptive problems. It's not simple. However, missing this form of maladaptation is also, frankly, a disaster. This form of maladaptation leads to poor educational and social experiences, generally leads to alienation and exhaustion of caregivers, and then leads to, among other things, social isolation, poor job performance, poverty, mental health and substance abuse issues, homelessness, victimization, and potential for antisocial behavior. We really aren't sure how many of these problems can be reversed by earlier understanding and intervention. But certainly by ignoring this form of brain damage and not explaining to the person and their family that he can't, as opposed to he won't, we're setting the person up for endless failure. It's sort of a little bit like asking a blind person to read the blackboard. And when they fail to read the blackboard, we tell them to try harder. And then after they've tried harder, we punish them. And after we punish them, we kick them out of the room. You wouldn't do that to a blind child, but this is done to people with FASD on a daily basis. But here's the problem. Mysterious maladaptation is mysterious. And it can be due to lots of different things. And we already have a lot of beliefs about what we should do with people who have adaptive trouble. If their adaptive problem is due to a disease, they have asthma and they're on medicines that are making them hyperactive. They have lung disease and they have air shortness and it makes them irritable. Or if it's in the environment, they're being raised by a family who's really very incapable of raising them. And this is the identified patient in a family of trouble. Well, if that's the reason for the adaptive problem, our societal judgment is that that's some sort of a disease or a problem state, and our goal is cure. We believe that that form of adaptive trouble is fixable. Well, what if the reason is that they have a temperament or mood problem? They have severe depression, an anxiety disorder, they're an obsessive child, or they have an ADHD problem that's significant. Again, our societal judgment is to medicalize that, to call it a disease, and to treat it, or we interpret it as disobedience. And then we aim to punish and fix and deal with it in an alternate way. Whether we see it as a disease or a disobedience, again, societally we believe this person should be treated, probably cured. And we believe in both of these conditions that initially it's our problem to provide treatment, but it's their issue to become cured. If the issue is cognition and performance, our societal judgment is either this is a disability or, again, it's a disobedience. If we see it as a disability, we're going to provide help and habilitation as best we can. If we see it as a disobedience, again, eventually we're going to blame the patient for the problem. This is really the fundamental reason for screening and final diagnosis. We know that people who are maladaptive are not going to do well, but they're not going to do well because of multiple reasons. And we have to know who's who and what's what. And at the same time we're sorting that out, we have to understand this wellspring of beliefs and feelings that society has about adaptation. So getting to clinic and getting the neurocognitive evaluation establishes that the maladaptation is due to brain dysfunction. It also is immediately a template for beginning an intervention pathway. So why should we do screening for FAS now? We understand that the brain damage is difficult, that our clinics are inadequate to meet the full need, and that we don't meet all criteria for screening according to the World Health Organization. Well, we believe the diagnosis of brain damage is therapeutic in itself. This shifts the collective interpretation of the individual's problems from he won't to he can't, which is important for the kids who do get evaluated. And it allows for the right intervention programs. And it remains an important way to get to the mothers. And if we don't start now, when will we start? So, how can we effectively screen for fetal alcohol issues now? This problem has actually been recently addressed by a group of clinicians across Canada who were called together by the Public Health Agency and CAFC to review the literature and opine on what screening techniques could be used. I was one of the authors of this study. And we took each aspect of fetal alcohol spectrum disorder and looked for its utility as a screening test. So we're going to talk about screening for alcohol exposure, growth assessments, facial analysis, and the neurocognitive file as screening tests. Now, importantly, there are two ways you could think about screening. One way you can think about screening is you just want to count in a community. You just want to know what the prevalence of something is. It's done anonymously, and it's not done with any promise of intervention. just how big a problem do we have. That's one form of screening. The second form of screening is to identify people who do not yet have the condition. They simply have passed a screening test and need to be referred to clinic for final diagnosis. The task force did not believe that screening anonymously in communities to assess numbers was the appropriate ethical approach at this time. And so the screening that's being talked about here is screening to identify people to come into clinic. Well, one way to screen is to find out who was exposed to alcohol. Now, of course, everyone exposed to alcohol during fetal life does not have brain damage and certainly does not have FASD. While the recommendation to not drink during pregnancy is medically accurate, we all know that some drinking is probably harmless. We just don't know how much that is in who. But clearly the number of people who still use alcohol to some extent in pregnancy is a much larger number than the kids who we can clinically identify on some level as having a problem with their brain or more. Nevertheless, there are basically two ways to approach this. One is meconium testing, and the other is getting an alcohol history. Getting an alcohol history has often been found to be unreliable and inaccurate. One is not surprised by that. After all, how many people in this room can tell me what they drank on February 19th, 2008? Would you all write it down now? I mean, and we're asking women a loaded question 5 to 8 years after the fact. The only way anyone can remember what they were drinking is if they're the kind of person who drank the same amount every day and remembers that in a certain period of time they were drinking a 6-pack of beer every Friday and Saturday night, or they were drinking wine with dinner every night, or something like that. For most of us, drinking is an irregular experience. We drink some days and we don't drink other days. We might drink a little, and on other days we may drink a little bit more. And no matter who you are, whether a little is 1 drink and a little bit more is 2, or a little is 3 and a little bit more is 15, it's different on different days. Not only is that a problem, but what went in the glass? The only people who seem to remember what they drank reliably are beer drinkers, because beer drinkers tend to drink whole cans and bottles, and they don't tend to share that. Everybody else takes a bottle of wine or a bottle of hard liquor, and they pour it. And they pour it into a glass. And unless they drank the whole bottle all by themselves, really nobody knows exactly how much they drank. So it really is a methodologic problem as well as a memory problem, as well as a socially and emotionally loaded problem. And some people, furthermore, are afraid that if they give you the answer, it's going to come back to hurt them in some way. So there's even reasons to lie if you know. So why should we be surprised that it's hard to get accurate alcohol histories? Well, there is an alternate approach to answer this question. There are alcohol metabolites called fatty acid ethyl esters. Now, it turns out that in the developing embryo, there are a number of natural alcohols that are made. And so the fetal liver is organized to metabolize those normally occurring alcohols. And therefore, we retain in our livers for the rest of our lives an organ that can also metabolize ethyl alcohol, which is why we've been able to drink it. So fetuses are actively metabolizing the normal alcohols into these fatty acid ethyl esters, which then go into meconium or fetal poop. If moms drink alcohol, that's metabolized by the mother and the fetus as increased amounts of FAEE. And the difference between the baseline rates and the rates that can be achieved by women who are drinking in pregnancy are substantially different. Unfortunately for us, this whole process of developing FAEs is done in the second half of pregnancy. So when a baby is born and they pass meconium for their first or second bowel movement, that stuff holds on to all of the fatty acidetyl esters that have been produced in the last half of pregnancy, not the first half. And certainly finding that would place a pregnancy at high risk. Now, if there's a discrepancy between finding high levels of FAE and what the woman just told you, all you've learned basically is that the mother is a liar. And it becomes a very important question if that's something we want to know. More importantly, women can tell you that they didn't drink, and if they didn't drink in the second half of pregnancy, the FAEs will be normal. But much of the brain damage occurs in the first few weeks of pregnancy, in the first half of pregnancy. So the baby could be at very high risk and pass this test. Similarly, if she only drank at the end of pregnancy, the baby's probably at relatively low risk, and the FAEs may be quite high. So this test exists. We all remain a little perplexed by how to use this test appropriately for screening. The press have incorrectly, endlessly said that this is a test for fetal alcohol syndrome. And of course it's not. It's simply a test to prove right or wrong the mother's history, self-disclosure of alcohol use in pregnancy. And this may set up, if we use it as a screen, a real ethical dilemma for us if we now have a secret. We know that a woman is drunk. She's chosen not to tell us that. How are we going to handle that situation? Okay. So screening for alcohol may not be really ready for prime time. Well, what about screening for growth deficiency? Well, it turns out that growth deficiency has been overstated in the literature. The first cases of what was first called fetal alcohol by Dr. Smith came out of a growth deficiency clinic. So all the kids that were initially found to have fetal alcohol were severely growth impaired. Nancy Day and others have done very careful work on this condition, and alcohol does impact growth. But the impact on growth is generally relatively subtle. So in populations of children exposed to alcohol, compared to their peers and compared to their siblings, they're somewhat smaller. That is to say, someone who genetically should have been in the 40th centile might be in the 30th centile or the 20th centile. Now that's quite a bit of growth deficiency. But when a clinician looks at a person who's in the 40th percentile or the 20th percentile, they say they're both normal. And it's very difficult to calculate the growth impact on an individual and figure out what their trajectory of growth should have been without a prenatal event. Children who are clinically growth retarded at birth or persist in being small have usually had massive exposures to alcohol at the end of pregnancy. So it's not linked to the facial anomalies and the brain anomalies which tend to occur at the beginning of pregnancy. As I said, it's only found through large case-controlled studies. And when people have looked at populations of children who are in uterine growth retarded, who are really little, in fact, alcohol does not pop out as a common cause of that disorder. Lots of other things cause that, but this doesn't seem to be one of them. So if you're getting lost, we are now up to page 14 in your slides. We're about to be on the top slide on that page. I'm going to skip FACE, although it comes in the order at this point in the usual way we think about things, and just do neurodevelopmental profiles first. So should we just screen for a specific neurodevelopmental profile? Well, there is no specific neurodevelopmental profile. As I said, why should there be? We're diffusely damaging the entire brain. We're damaging it in different ways. We're damaging it against everybody's original genetic profile, which has some differences in it. And so it would not be surprising that everybody comes out with a different explanation for their maladaptation. There is no screening profile, per se. Diagnoses like intellectual handicap, learning disabilities, attention deficit disorders, and many others certainly describe some of the people with FASD, and of course they describe people without FASD. And none of these functional diagnoses are particularly helpful in finding a subpopulation of people with FASD. Now, attempts are being made to develop a test that captures global maladaptation as a primary complaint. Since that's what's wrong with these kids, why don't we go for that? And several of these tests of maladaptation do separate the FASD population from children who are normal. But there's been strikingly little correlation or testing with other groups who have brain injury from other causes. So, can we separate a child with a diffuse pattern of brain damage from normal folks? Yes. Can we separate FASD from people with traumatic brain injury? Not clear that you can at all. On your list, there are several different tests that are currently being evaluated to see if they can be used to screen using this technique. But again, at this point, we really don't know the sensitivity or specificity for any of these tests. And they're not that simple to use. As screening tests, these are all fairly extensive tests on their own. What about the face of FAS? What's amazing about this face is that it appears to be very specific for alcohol exposure and finding neurocognitive and performance deficits. When we see that face, that whole face, it's been virtually 100% sensitive and specific. You will find a history of alcohol exposure. You will find that the brain is not normal in performance. Face is very powerful. The face is just simply rare. We're not exactly sure in what percentage of people the face occurs in. In Washington State, where the test of face was first developed, we find that in appropriate referrals, about 1 in 10 kids who comes into clinic and gets some diagnosis of FASD has the full face of FAS, 1 in 10. We do not know what the ratio is in Canada in any clinic at this point. But of course, this is that one feature that separates the syndrome from everything else. Now, in the next two slides, which are on your page 16, there are four pictures of faces, which on my slide are taken as one picture. You can see that these children do not look identical. They have a racial appearance. One little kid looks Irish. One little child looks Mexican. One little child looks like they come from a First Nations background. Another looks perhaps to be South Asian or Japanese or something. Hard to tell, but they don't look like they're racially the same. You also can tell a little bit that they're boys or girls, partly by their dress and their haircuts, partially by their facial profiles. And I'm sure if they were standing next to their parents, they would look something like their parents. But what is it about these faces that makes a dysmorphologist say they're all the same? We studied that with photographic and computer analysis and actually found that there were only two features that were really separating these children. And one of the features we divided into two parts. But one is the size of the palpebral fissure, and the other is the size of and shape of the upper lip and the furrows between the lip and the nose called the philtral contours. In fetal alcohol syndrome, the contours of the philtrum get flattened, and the volume of the red part of the upper lip decreases. So you go from a full upper lip to a thin lip. Philtrum goes from being full to flat. As you get older, this happens again. So it becomes less of a marker in adults. This probably embryologically is a single anomaly. But as we look at different people's faces, it turns out that you can have a thin lip or a flat philtrum for a large number of reasons. And it's only powerful when they're both present at the same time. The palpebral fissure has to be measured very carefully from one of these points to the other. If you have skin in front of your eyes, if you have eyelashes in the way, if you're squinting, if you have epicanthal folds, you can't accurately measure how big the eye slit is. The eye slit is itself a proxy for the size of the orbit. The orbit is in fact driven by the size of the eyeball. So a small eye slit means you have a small eyeball. The eyeball is, of course, a part of the early brain. It's the part of the brain we can see. We use it to see with, and we also can see your brain with it. It grows until your face is fully formed. Both eyes are generally the same size to within a millimeter. There seems to be little difference between men and women. Women are about a half a millimeter smaller than men on average, which is below the clinical ability to read the difference with a ruler. To some extent, it correlates with hit size. You've got to move the tissues out of the way to see it. And there has been no data on Canadians until now. Our research network has just completed the first broad study of normal palpebral fissures in the Canadian population. We've measured people of all ethnic backgrounds and origins. And we've measured about 4,000 children from grade 2 to grade 10. We can assure you that racial background does not make any difference in measuring palpebral fissures. We can put everybody on the same grids. Black Africans have slightly larger eyeballs than Caucasians and First Nations folks. Caucasians and First Nations have slightly larger palpebral fissures than Central Asians. But they're all close enough that it really doesn't matter. Furthermore, the normative charts that are being used in Canada are incorrect by about 1 standard deviation. Okay, so you could use faces for screening. Faces have been used for screening. You can take pictures of children in schools. You can take pictures of children in foster care. You could take pictures of every child in a community. You could just take pictures of their lips and eyes so you wouldn't even know who they were. This technique is ready for prime time, but it's a very small slice of all of the population. But this could be done. It's the only one that's technically available, but it's only going to pick up a small number of folks. So what are we actually using now? Clinics are running in Canada. They are running every day all over Canada, especially here in Western Canada. How are people coming in and what are they finding? We thought we would ask. And so Jan Lutke and I did a study where we simply identified all the clinics doing FAS in Western and Northern Canada using the Canadian guidelines. We asked them a few simple questions about who they were seeing and what they were up to. Between January of 2005 and April of 2006, approximately 1,141 FASD assessments were done by those 15 clinics. And you can see on this slide, which on your graph is on page 18, the bottom slide, some very interesting things. When those 1,141 kids came to the front door, the referral question was, does this child have a form of FASD? So that was the presenting question. And the answer, 70% of the time, was yes. At the end of the clinical assessment, they do have FASD, 70% of the time. That's a fabulous screen. So if you're seeing 7 out of 10 people have the condition you're seeking, that's important for the 7 and it's important for the 3. Because the 7 need to know that that's what they've got, and we can now start dealing with their mysterious adaptation because we've done all the testing to do that and we know that's what they've got. For the 30% who looked like that but have something else, it's also critically important to know that they don't have FASD and to know what else they might have, which might be treatable or potentially curable, and takes them down a completely different road. This slide by itself is the reason that I'm afraid of screening right now in Canada. Because if we screen and screen and screen and don't have a capacity to do final diagnosis, anyone who's screened positive is going to leap to the fact that they have FASD. And there's going to be some significant proportion of those folks, no matter what test we use, who won't. Furthermore, if we drill down on this slide, we see a few other things. In different communities, the percentage of folks who have FASD versus something else differs. So in Manitoba, less than 50% have FASD. In Saskatchewan, 80% have FASD. That's interesting, and we don't know the reason for that. Is that because people are seeing different populations? Is it because they're diagnosing differently? Is it because they've just been in practice longer periods of time and maybe they're seeing more subtle things? We don't really know the answer to that. But there are going to be variations from place to place. And again, when we start using screening to drive diagnosis, we need to know what people are really doing when people come to clinic. So at the end of the day, population-based screening is not yet technically ready, nor do we have the capacity to handle referrals. But clinical screening does seem to be fairly effective right now. How did those folks get to clinic? The clinics were just asking 2 questions. Basically, they were looking for a spontaneous history from the family or the referrer of mysterious maladaptation. They got a story like, oh, this child has the worst ADHD ever. He's been on 4 medicines. Nothing helps. He's having trouble now that he's in grade 4, and he's driving the kids in the neighborhood crazy. And we don't know what's going on. Good enough for me, mysterious maladaptation. And, oh, by the way, his mom was a drinker. That's all it takes. That's all it takes. We don't really have to do all this complicated stuff. Asking those 2 questions in a supportive and sensitive way leads to 70% findings of FASD in clinic. When in life should we be doing the screening? Well, there is a strong belief, almost an ethical belief in the developmental world, that the earlier a diagnosis is made, the better off you are. Who would debate with that? No one. We can't make these diagnoses with this technique until kids can be tested. So as long as we are relying on a neurocognitive profile for diagnosis, we can't do this until kids are 5 or 7 years old, because they just don't have enough brain that's developed to the point that we can test it with this degree of precision. And earlier tests of development done in 1 to 5-year-olds actually have not correlated very well with finding this kind of diffuse brain damage when we get there, unless the developmental delay is profound. When kids are developing at 50% of normal or worse, of course, that's very predictive of ongoing trouble. But if you're not that bad, the kids who are at 70-80% of normal development do not necessarily show persistent diffuse anomalies when they're tested later on. One of the things that surprises me is our resistance to an at-risk category for FASD. What do we do with kids with cerebral palsy? For example, a baby is born after a terrible delivery. Low Apgars, turned black, things didn't look good. He had seizures in the newborn period. His tone is terrible. His suck is awful. Very high risk for brain damage. His MRI looks abnormal. Do we go in and tell the family that the child has CP? Absolutely not. Why don't we tell them that? Because we might be wrong. And because that diagnosis suggests that your child is going to be brain damaged for the rest of his life. What do we say? We say this child has had a very rough start and is at risk for persistent and permanent brain changes. But we really don't know if that'll occur. So what we want to do is put you in a really good developmental program, and we'll see how it goes. And if we're lucky, he gets better. And if we're less fortunate, the child has persistent problems. And so at the age of 1 or 18 months or 2, we finally make a diagnosis of cerebral palsy, which at that point does not come as a horrible, scary thing for a family, but rather is welcomed as a diagnosis that buys continuing services. Why can't we do the same for our risk population? A child is exposed to significant amounts of alcohol, and as a little child is having persistent mysterious maladaptation. Why not just say at risk? If we want early diagnosis, which everyone's demanding, it logically suggests that after that diagnosis you'd be putting people in a developmental program. Well, why not just put them in a developmental program? It would serve 2 important purposes. One would be that if they were in a developmental program, we could track their development and maximize their chances for normal development. We could also be watching their families. Many children who have FASD are still living with their birth families who had a problem with alcohol and possibly other drugs. They may be having trouble parenting. And if we have them in a good supportive program, we could not only be watching the development of the child, but we could be helping the development of the parents. It changes your whole idea about what screening might be. And using this key of mysterious maladaptation and an alcohol history, not just to get to clinic, but to develop a holding place until we know what we're doing. Now, these are the words that eventually get used in our field to describe brain damage. Static encephalopathy, neurodevelopmental injury, prenatal brain damage. We don't really have a good term. But what all of these terms mean is they put the lesion in the brain. They're diagnoses of location. Where is it? It's in the brain. They're diagnosis of pathology. The brain is injured. But the patterns are abnormal in different ways, and they're abnormal in different degrees. And so this always just presents again as this mysterious maladaptation, and there's this huge discrepancy between these terms. As a final point here, before we move on to another topic, I want to just tell you a little cautionary tale, again to emphasize why leaping from screening to diagnosis is really a scary business. This is sort of a true story that comes from the annals of the FAS clinic. The mother says to her child, "Please don't run in the street, you could be hit by a car." What did I just say? And the child replies, "I will not run in the street, I can be hit by a car." And they play this little song over and over and over again. She asks the question, he answers the question, it's perfect. So she finally opens the door and lets the child play in the yard, and the child promptly runs across the street. So why did the child with FAS cross the road? And this kind of a question is asked on the web on a regular basis. It's asked to family support groups who try to provide answers. My child has this condition, this is the behavior, what is the link? And that's all you get. The problem is when you get to clinic and start drilling down, the answer can be radically different. Even in people who have FAS. It could be a concrete language problem. What, after all, was the rule? The rule was don't run in the street. For someone with concrete operational language, that translates into a vision in their head of running down the yellow line, running in the street. He didn't run in the street, he ran across the street. And as he understands language, he didn't break the rule. He's innocent. It's a little bit like Amelia Bedelia. You remember those books? We see people who have FASD conditions who are just like that. Very literal, get very upset, call you a liar when you use language in ways that are more global. Okay? Could be a memory disorder. Can't remember the right rule at the time to apply the rule. Remembered the rule, but not when he needed it. Very different problem. Could be impulsive, and impulsivity mixed with an executive function disorder. So impulsivity overdrives other aspects of planning. And the planning just isn't there when impulsivity is pushing. But he could be a risk taker, just likes the thrill. He could be oppositional. The hell with mom, I'm really tired of that rule. And the scariest one of all, he's depressed. He remembers the rule just fine, thank you very much. Even in the context of a diffuse processing disorder, when we get down to the level of trying to understand a specific behavior, the cognitive profile, the mental health profile, the environmental base profile, all need to be strongly considered before we venture to provide any intervention. If you understand any of these findings, this child can be helped to improve. Without understanding this level of behavior, all we can do is keep the child in the house or in a locked yard. Control will always make your behavior look better, but it doesn't internalize your behavior. So we're now up to page 21 on your slides. So in the end, alcohol means your brain's damaged. The alterations are on a continuum from mild to severe. They are associated with functional problems that are also on a continuum from mild to severe. The identified alterations may or may not be the cause of a particular action. And it's easy to make a mistake in interpreting behavior without careful evaluation of the possible reasons. The fundamental rule of medicine is do no harm. You can be wrong when you screen, you can be wrong when you diagnose, and you can be wrong when you interpret a behavior. We have to do our very best job at each level to minimize being wrong. Here's the final problem with screening. So in an ideal world, a professional would consider FASD as a possibility when worried about mysterious maladaptation or an alcohol history. He'd tell the family about the concern. He'd refer the family to an FASD diagnosis center that would determine a positive screen and understand things, and a full assessment would be done, and we would give people the best shot at the correct diagnosis and the correct approach. There are two problems with this scenario that everyone that's listening to this lecture should think about. The first is when the professional says to the family, I think that this is a diagnosis you should consider, what does the family hear? And then, how long will they have to wait before they can have somebody help them deal with what it was they heard? When people are told their child has a birth defect condition, it doesn't matter what it is, there is almost always a sense of responsibility and sometimes guilt as well. There is a sense as parents that we are responsible for the problems of our children. Can we talk? We all know this. It doesn't matter what it is. We're responsible. It's part of being a parent. But when you tell parents that they have something that's come from their loins, that somehow changes it a little bit, it means you're somehow on some ethereal level more responsible. It's not rational, but it's almost always there. We might imagine that these feelings are weightier when an action in pregnancy did in fact cause the problem. We might imagine that. We might imagine that a woman told that her kid has FASD might be more anxious than if we told her we thought the child had a genetic condition or something else. I'm actually not sure that's true. There's very little evidence to suggest it's true. But it's not better. There is real weight to all of these diagnoses and huge anxiety that is produced in parents as a result. Do the parents also hear when we say FAS that we think that they are fetus abusers? Do they think that we think they're fetus abusers? I don't think that's very many people's intentions. But you know, again, people read the newspapers and they've read about moms being locked up for using alcohol and drugs in pregnancy. And they know that that people are tarred with a bad brush when they are declared doing these things. And while it's not our intention, the word itself inherently says, Mom did something. And so while they may not be, on the one hand, more aggrieved than any mom would be that their child might have a persistent problem, they may be more aggrieved about the wonder about what it is we're thinking about them. And if this diagnosis is coming out of a system that does not hold with high medical confidentiality, like a school or like some screen in a community, we're setting up two kinds of anxiety in folks. They're worried about their child, and they're worried about what other people might think of them on one level or another. So what, at the end of the day, is our responsibility if we're going to screen for training those screeners to be available to effectively help families to process this information immediately? Because given the gap between the number of slots for diagnosis and the number of people who may be helped with a screened diagnosis, there will be a time delay. And it's just not fair that people are sitting with some level of this anxiety and confusion. I believe that any screening procedures that we put into place need to have a very effective and sensitive training component around the weight of the screened positive situation all by itself. By the way, after doing this work for 30 years and meeting an awful lot of people, I have never, ever, not once, met a birth mother who drank in pregnancy because she wanted to harm her unborn child. I'm sure there is some human being out there somewhere who did, but I've never met her, and she's a real rare person. So just to understand the fact that while people worry about all this stuff, that's not who we're finding. But who are we finding? Well, it's very interesting that in Canada and the United States, the vast majority of patients diagnosed with FASD are in fact in foster adoptive circumstances. Why is that? Is it because that is where the patients are? That in fact another screen for FAS is that we are plucking these kids out of their homes at a very high rate because we're interpreting their early maladaptation as environmentally based? Or because alcoholism and drug use is one of the highest likely reasons that you're taken away from your parents? Or is it because we're actually reluctant to talk about this with birth parents? Because of all the reasons I've just described. Maybe we don't even articulate that to ourselves. So we're comfortable screening when we're not directly talking to the birth mom, and we don't do it when we are. Those are both reasonable hypotheses, and we do not know the answer. But because so few birth parents come to clinic, clinicians have had limited opportunity to describe birth parents. I told you at the very beginning that the FAS diagnosis was really primarily a diagnosis for identifying whole families and identifying moms who are going to make more kids with FAS. That the kid is, in fact, a birth marker. So we can screen for the children using some of the techniques I've described or not. We can also screen for the parents, either using their kids or going about it through other ways. So what do we really know about the profile of people who have children with FASD? Well, obviously they drink, but is that all there is to it? Back at the University of Washington, we had made a diagnosis of full fetal alcohol syndrome in 160 children over a 3-month period. I'm sorry, a 3-year period. We then got a grant from the CDC, the Centers for Disease Control and Prevention in Atlanta, to do a study describing the birth mothers. So we went back to those records of 160 folks. 10 of those children were living with their birth parents as primary caregivers. All 10 of those women were at this point long and deep into alcohol recovery. "80 of the women had been completely separated from their children. So 10 plus 70 more were at some level still in their kids' lives. 40 of the mothers were involved in systems within the state, so they were separated from their kids, but known to social service systems, the criminal system, something. But for reasons of medical confidentiality, that information could not be shared with us. 40 of the mothers were missing or dead, literally dropped off the face of the earth. Now, if you think about fetal alcohol syndrome as a biomarker, how many biomarkers do you know for cancer where 25% of a population is dead within 3 years of the biomarker being found? At this point, very few forms of cancer still hold that kind of a death rate. This is a staggering number. This study has only been replicated once. It was replicated here in Western Canada, and the findings were virtually the same. Well, we were able to find the 80 women who were still involved with their kids by phone. We called them up, and we said that we were doing a study on children who'd come to a developmental clinic, and we were looking to interview birth mothers. That's all we said to them. We never told them that their child had FAS. Based on what they were allowed to know about their children, we had scripts available, so when they asked, we could tell them what we could. Not one of them ever asked. But about half of them said at some point, well, I'm sure this has something to do with the fact that my child has FAS. But they didn't really ask. Anyway, they all agreed to an interview. It took a lot of time often to get them into the interview. And during the interview, we did a number of standard things. We gave them all IQ tests, themselves brief IQ tests. We looked at their lives. We really tried to draw them out. They came from basically the majority and minority populations of Washington. The majority were Caucasian. There was a somewhat larger sample than population-based for First Nations or Indians in the United States. There were a few too many of those and a few too many Asians. But largely it looked about like it should have looked. The population had started at every level of society, but at this point most of them were on the very bottom, living in abject poverty. They had a reasonable distribution of IQs. However, there were far too many people who had IQs below the range of 70 who were intellectually handicapped. Every single one of these people reported a lifetime of experience of extreme sexual abuse, physical abuse, and emotional abuse in some combination. The stories were so horrific that the nurse who did the 80 interviews requested and received therapy that continued long after the study was over. And nearly all of these people had long-standing battles with alcohol use and abuse. So on a DSM, you'd think that all of these people would have two diagnoses. They'd have a substance abuse diagnosis, and they would have a post-traumatic stress diagnosis. But the vast majority also had diagnoses of depression, manic depression, and phobias. Agoraphobia, fear of leaving home, was the most common phobia occurring in almost half the women. There was too much schizophrenia and too much psychosis. The average patient had 4 DSM categorical diagnoses, and 2 had 10. That's as many categories as there are. There was remarkable social isolation. We had a test where we looked at sort of the Bronfenvenner achistic circles of community. Who's in your family? Who are your friends? What clubs are you in? What does your neighborhood look like? Who do you meet in society? These circles go out and out. And the average person listening to me this morning should have a score of between 80 and about 120 on this particular test. These people usually came in with scores of 3 or 4. Very, very, very socially isolated people. We estimated that the reason for those low IQ scores was that about half of these women had fetal alcohol themselves. About half. And when they went for mental health treatment, they were told to go for substance abuse treatment. And they went for substance abuse treatment, they were told to go for mental health treatment. Now let's think about people with agoraphobia, social isolation, substance abuse trouble, untreated mental health problems and FASD, and you tell them to show up next Tuesday for an appointment. And that appointment, if they get there, tells them that won't work for them, they should go to this other appointment. How is that going to work? But what they discover on their own is, do you know when they get services? When they're pregnant. Their best access to care is during pregnancy. And so all of a sudden we realize that for this group of folks, badly abused, mental health problems, brain damage, alcohol and drugs, their best self-medications for their mental health disorder. Babies, their best social intervention. And everybody's got a story of seeing the grand multipida who comes in on their 9th pregnancy, still pregnant, they've lost 8 kids, and you say, Gertie, why do you keep making babies? And she says, because you keep taking them away from me. And everybody goes, ha, ha, ha. That Gertie. But Gertie's telling you the truth. This is not new information. This study was published more than 10 years ago. It's only been replicated once, but it was completely replicated. Where are we, guys? Why are we letting this happen? Why aren't we using the children we are diagnosing as the screens they are to help these women? Why aren't we reaching out to them better than we are? And why aren't we documenting that we're doing it? Common picture. Lots of problems with this picture. Who's in it? Who's not in it? The most common question that I always get at the end of pregnancy is, what about the guys? Why aren't they in the picture? If you're screening for FAS, why aren't you screening the guys too? And the answer to that is, because we should. I'm not exactly sure how, but it's really an important thing. Women drink with men or because of them. Babies are all about all of that. It's a whole other area that needs to be explored. There's very, very, very little data about the guys. So when you're really talking about screening, what my bureaucratic friends and I really leap to is capacity building. Because the only reason to screen is so you know how much you need to do. The diagnostic model exists. It's not big enough. It has not been a simple matter to identify qualified personnel and train them to function as teams doing this kind of work. We don't know all the reasons for that. This is a different way of doing business. We ask professionals to step out of their isolated work one-on-one with families and work collaboratively with teams of people in different fields. Everyone hasn't been trained, and frankly, everyone isn't comfortable doing that. Especially people who work with adolescents and adults don't seem particularly comfortable with this model based on their training or their practice alone. But it doesn't seem like an inordinate task to find the people who are comfortable and train more to be comfortable and work in this way. Until we actually can solve the problem of manpower, we're not going to be able to deal with our inadequate capacity to deal with this problem. People say it's expensive to do this kind of an evaluation. It isn't really. It's time intensive. It costs a few $1,000s. We do MRIs that cost about the same without very much challenge. If we had cancer and 25% of the people were dying within 3 years, I don't think there'd be a politician in the country that would say a $4,000 evaluation was a badly spent piece of change. But it's bigger than money, and money is not our problem. If we had all the money we needed today, we wouldn't have the professionals to do the work. And again, as you sit around these tables, many of you are of the converted. We need to understand how we get more people to understand this approach and to find it fun and helpful and interesting, because it is. As I said, that in Alberta, there may be as many as 30,000 folks with FASD, with a population of 3 million. Our annual capacity in Alberta for evaluations right now is 350. It's the goal of the province to crank it up to 1,000. That's good. The good news is you'll be ahead of everybody else in the world in terms of your capacity relative to how many people are out there. The fact of the matter is you're still woefully behind. And my guess is, as you go from 350 to 1,000 evaluations, your waiting lists are going to get much longer, not shorter. So, in conclusion, screening is not diagnosis. Screening is, on the one hand, very simple, but also very complicated. Care and sensitivity and understanding the power of the potential of the diagnosis needs to be considered at every level. Diagnosis is important for understanding the mother, her family, as well as the offspring. And the system will not be able to work well until we solve the fundamental problems of developing capacity to do the diagnostic work. So that is the end of this talk. We have about 20 minutes left, and I was told that people frequently had good questions. Hopefully, I've been so clear that there aren't any, but if there are, I'd be happy to take them at this time.
I have one.
Yes.
That you may not feel comfortable answering, but I'll ask it anyway, because I'm a lawyer, I do defense work, and often what I'm looking for is someone to do an assessment on a client.
Mm-hmm.
What do I look for in it? Because as you know, and I don't know if this is similar with other provinces, but I can tell you that even in Edmonton, we have different people saying different things and arguing with each other about what is the right way to do things, what is the wrong way to do things. So, and I don't know, I'm not a doctor. So what do I look for? Can you answer that? Or?
Oh, I'd be happy to share what I know.
Please.
I'm in court all the time. In fact, my mother has stopped being rattled when I tell her I'm going to jail. Okay. Have people out in the hinterlands heard the question, or do I need to repeat it? The question comes from a lawyer at the table who says, how does all of this basically play out in preparing a defense, and how does the diagnosis of FAS work in trial? From my standpoint as a doctor and not as a lawyer, it seems to me that there is sort of a cross-hatched way to answer that question. There's sort of an x-axis and a y-axis. And one axis is the nature of the crime. At some level, the crime is fairly trivial, and a person with brain damage should be cut some slack, especially if we can deal with him early in his criminal career and habilitate him and get him out of that system. But as you move along that continuum, as his crime becomes more serious, protecting society has to become a more important value. And so that's sort of one continuum. Of course, there is no final answer, because you have to know and argue where along that spectrum this individual is. The other axis has to do with what's the nature of the brain damage and how does that relate to his criminal behavior. Just as we were talking about why someone ran across the street, if we can do the testing and understand that this person has a very focal kind of problem with executive functioning and memory that's coupled with, some sort of a rage disorder that's in his limbic system, and we really, really understand why in certain circumstances he may do certain bad things, then that will help us to understand that first continuum of protecting him and helping him versus protecting society. Frequently, however, it's been my experience that the testing is not that precise. And we get the testing done and we conclude the person has some brain damage or brain injury, but we really don't know why he raped and murdered someone. It still remains mysterious. For my money, arguing the big picture word FAS is pretty useless. It's been my experience that many lawyers like to do that because it's pretty easy. But when you get to the jury, it's always seemed to me when I've been in court that they're not taken in by some global and confusing diagnosis. They really do want to know how you link that brain damage to what he did. And frankly, sometimes that's really, really hard to do. So that's the situation. Confusing? Absolutely. Open to argument? Almost every time? Absolutely. But, you know, again, we may be focusing on the wrong people. If we spend our time worrying about how to adjudicate murderers, I don't think this is a very interesting question, frankly. Mary Ellen Turple-Lafont, who's a judge from Saskatchewan, who's now the child advocate for British Columbia, talked a couple of times at meetings I was at recently about, you know, adolescents who came before her court repeatedly. And she was sure they had FAS, and she was hoping that they could do something to get them diagnosed and out of the track they were on, and hadn't been very successful. But I think she's onto something important. Where we should be putting our energy in the criminal justice system is really early. Find these guys and get them out of there. Again, we have to be very sensitive to what's in the press. The more there are terrifying stories of what people with FAS have done, the more everybody runs away from the diagnosis. I mean, who wants their 7-year-old diagnosed with FAS when there's a story in the paper about some guy who's hit a social worker over the head and killed her? And so the more we can do to discouple these two findings, I think the better off we'll be. Any other questions? Anything else? Okay. I heard that there are 250 of you out there. Now have a little pity on a poor guy who answers his own email. You've got my email on the last page. I've left it there on purpose. If you have a burning question that you think I can answer, by all means send it to me. If you think someone else can answer it for you, go there first. Thank you very much.